Hi, this is Elliot Fishman, and hopefully live. This is CTisus. This is our quiz, 12 great cases. Let's get started. Rule out appendicitis, which means this was an incidental finding. There's a mass in the right paraganglionic region. It's vascular, somewhat centrally necrotic. What could it be? A large node? That's a possibility. It could be a tumor, a carcinoid tumor. That's a possibility. It seems separate from bowel. It seems separate from bowel. It seems separate from everything else, just well defined. You can see it pushing on the aorta or near the aorta. You can see it very nicely in the cinematic rendering as well. Really, really nice example showing you this mass. And what is it? A hypervascular mass. The number of things you could think about, and I mentioned some of them, tumors and things like that, but what kind of tumors are vascular, well-defined, kind of sitting over there in the paraganglionic region, and a very classic one is a paraganglioma, okay? Paraganglioma is a really nice example of one of those possibilities. A really great case, right? Another case, abdominal pain. And you see a dilated pancreatic duct. It's markedly dilated, the entire duct, and you track it toward the head of the pancreas. We're looking for a transition zone. There's a soft tissue mass here. Look at the size of the pancreatic duct. Now you could say there's a mass proximal obstructing it, or you could say there's a dilated duct, loss of cortex, and what you're dealing with is a main duct IPMN, which are prone to develop malignancy. And so when you see a huge duct like that and a soft tissue mass, you got to say this is going to be a tumor. Now theoretically it could be a tumor obstructing the duct, but the duct is markedly dilated. This was a main duct IPMN, and the thing I mentioned, you can see it here, multiple views, and the soft tissue lesion right here was a 15 millimeter carcinoma. When you have main duct IPMNs, there's a higher incidence of malignancy. People will often operate when the duct is over 8 millimeters. This duct is larger. If you don't resect, you better watch very carefully because you're going to develop malignancy, as you see in this case. Great case. Incidental findings, cystic lesion, body of pancreas. The distal gland is atrophic, but there's not a dilated duct present. The lesion is cystic with septations in the body of the pancreas. Patient's age would make a difference. Body of pancreas, 40-year-old female, you're thinking about mucinous cystic neoplasm or MCN. Also, you got to think about serous cystadenoma, though that's less likely. It doesn't have the look of a routine IPMN. I guess a SPEN, a papillary epithelial neoplasm, would be a possibility. You can see the rest of the gland is also somewhat atrophic. So it's this cystic lesion. The consensus was MCN. This was a serous cystadenoma, making the point there are many different appearances for serous cystadenoma, and you cannot always tell between an MCN and a serous cystadenoma. Another case, rule out pyelo. Well, I'm giving you the kidneys. There's no pyelo, but there was a cystic mass in the body of the pancreas with septations and calcification, right? So what are you thinking of? The same differential as the last case. Could it be an MCN? They have calcifications. Could it be a serous cystadenoma? Their calcifications are more commonly centrally located, but can be anywhere. If you look carefully at this lesion, there's lots of septations. Looks like multiple cysts. We have commented before that it's easier to see multiple cysts on venous than arterial phase. And here it is with the volume rendering. And you can see on the venous phase volume rendering, it looks more cystic. There are more septations. The more septations to me pushes me to serous cystadenoma. But I have to admit, the right age patient, if it's a 70-year-old, serous is easy. If it's a 40-year-old, it's a mucinous tumor. Here it is nicely on the cinematic rendering as well. And this was a serous cystadenoma. Again, a great chameleon. Another case, cystic lesion, but an enhancing rim. When I look at this case without thinking, I say this is a neuroendocrine tumor. Neuroendocrine tumors are typically vascular, but they can be somewhat cystic with rim-like enhancement. 2 centimeters, that's a good size. The smaller the lesion, the more likely it will be followed, because these lesions can be grade 1, where the following will be adequate. 2 cm is kind of the borderline what people think. But what else could this be? It's an enhancing rim, and I've showed you some funny serous adenomas with enhancement, but I have to admit, to me, this is a neuroendocrine tumor. It's not an IPMN because it's enhancing. It's not an adenocarcinoma. Here it is on venous phase, where the rim is a little bit less well defined now. The lesion is well defined. Here it is on the cinematic. And guess what? It was a serous adenoma. My money was on a neuroendocrine tumor. Patient was lucky. It was a benign serous adenoma. Another patient, vague abdominal pain. Same location, cystic lesion. This one is well defined, sharply marginated. I would have thought about a lymphoepithelial cyst, which are benign but can be large. The water density, they kind of scallop, which is kind of the appearance here. The pancreas, kind of body of pancreas. Could this be an IPMN? I don't see a dilated duct, or I don't see any duct rather. Could it be an MCN? ES, MCMs usually have some septations, not always. Could it be a serous adenoma? Oligocystic serous adenomas have no septations. But I'm telling you, I'm still saying, to me, this is a lymphoepithelial cyst. There it is nicely on the volume rendering. And guess what? Another serous adenoma. A lesson in being humble, right? It can be a very difficult call. For the patient, serous adenomas are a good diagnosis. They're always benign. They have no malignant potential. Another case, back pain. There's an infiltrating mass in the region of the adrenal gland, which extends in the paraortic region on the left and extends down in the peri and pararenal space by the kidney. It encases the renal artery. From the first images, you could have thought about an adrenal cortical carcinoma, but when you look at the infiltration down around the vessels, that's more of a soft infiltration. It's extensive. And things that go in the peri and pararenal space are typically going to be lymphoma. Very, very hot on PET scan, but an adrenal cortical carcinoma or a PET can both be hot. But this was a lymphoma. Again, the infiltration around the vessels. ACC might invade the vessels or displace them downward, not just simply encasing them. Another patient, hematuria, big mass, region of the right kidney, but you recognize when you get the coronals, this hypervascular lesion is really in the adrenal gland, right? Left kidney looks good, the right kidney looks good too. Hypervascular, necrotic right adrenal lesion. What gives you vascular lesions in the adrenal? Well, metastasis from renal cell, but the kidneys look good. You can get primary adrenal cortical carcinomas, can be very vascular, can be necrotic. Pheochromocytomas are very vascular, but they can be necrotic as well. Other lesions, hemangiomas, are rare, but this looks like an aggressive lesion. Lots of nodularity. Look at the vascularity on the MIP imaging. Look how there's involvement and extension into the renal vein. So this is surely a malignant tumor. I would favor an ACC, but I would at least comment, maybe get some labs, make sure we're not dealing with a pheo. Here it is very nicely shown on the cinematic renderings. And this was a primary adrenal cortical carcinoma. Okay, a few chest cases. Large anterior mediastinal mass, somewhat cystic. A key finding here is involvement of the internal mammary region and involvement of the chest wall. When I see in a young patient big mass, you go through the things, teratoma, but no calcification, and it wouldn't go through the chest wall. Thymomas are rare. Lymphoma is the thing that has cystic areas, like this case has, also involves the internal mammaries, can go through the chest wall. Next scan has involvement of the pericardium or extension near the pericardium. That looks like a big node on the right side. And that really pushes you again to the diagnosis of lymphoma. Here's some venous phase, the cystic components, the chest wall involvement, bulky tumor shown on the coronal views, very nicely shown, infiltrating around the vessels off the arch, really nicely shown. And this was a B-cell lymphoma. Another patient, large anterior mediastinal mass. Again, lymphoma is a possibility, teratoma is a possibility. A huge thymoma would be a consideration. It's not substernal thyroid. It does involve the SVC, so it's an aggressive lesion. You can see some of the collaterals. You can see how low the lesion extends. You can see how bulky it is. And you would have to admit, perhaps, except for the lack of cystic change, it looks very much like that lymphoma I showed you before. And I think this is where pathologists make their money, because it could be lymphoma, could be an unusual thymoma, unlikely teratoma, vessels patent. This was a neuroendocrine tumor of the thymus. Remember, thymic tumors, you can have carcinoids, you can have neuroendocrine tumors, you can have adenocarcinoma. Another lesion, cystic, eccentric, coming way up. When you first look at it, I would say pericardial cyst, but pericardial cysts don't typically come as high as this lesion is coming. Look at it on the coronal views. And so what are you dealing with? A great mimic of a pericardial cyst, and that's going to be a thymic cyst. Yes, thymic cysts are smaller typically. They're anterior mediastinum, but they can extend and hang downward. And this is unusual appearance, nicely shown the fluid density on the cinematic, but a really great example of a thymic cyst. Really great case. Okay, last one, IV drug abuse and fever. What is going on in the right ventricle? There's multiple filling defects. Could this be tumor? There are patchy infiltrates in the lung which look like septic emboli. There's a large mass in the right ventricle and septic emboli. And the patient has an IV drug abuse history. While looking at the rest of the abdomen pelvis, I'm not all that impressed. I don't see anything in the kidneys, but it looks like maybe an infarct in the spleen. Okay. And so what am I looking at? Look at the appearance of the trabeculae of the right ventricle. Look at the irregularity. Look at the mass effect. Should I be thinking tumor? That's the question I would ask. But look at this process extending up through the pulmonary